as we get into conversations this morning, good to have you here. And one who is no stranger to the Situation Room this morning is here. Senior advisor in the Council of Economic Advisors is Moses Kuria, and he is with us this morning. And we're getting into a number of conversations, top of them being the health system under SHA. And we start that conversation with him this morning. Good morning.
Morning.
Waziri.
Good morning. Muga.
How are you doing?
Happy New Year, people.
Happy New Year.
Happy New Year to you.
I see you have a new guest today.
Yes.
So the Gen Z fever is catching.
Telling you, umbrellas up, man. Is there? It's
Everywhere.
It's a good thing.
It's a good thing, isn't it?
Yeah.
It's a polite reminder that, 6% of Kenyans, only 6% are above the age of 60.
Yes, that's 6%.
So you need to be registered, man. At that convention called CITES, the convention for endangered species.
Oh my goodness.
So the protection,
Protection.
It's the Ministry of Tourism, isn't it? Yeah. The white rhino, people, Kenyans that are over 60,
Spotted turtle.
It should be, endangered species which need to be protected.
We're a tourist attraction now.
Somebody come far and wide to see you. So then also perhaps the 75% ought to be listened to at some level, isn't it?
Well, their noise cannot make them, the sheer numbers are just too much. And it's also a phenomenon across Africa.
Yeah.
I mean, it is just
It is why the continent is referred to as the
and it is up to us what we want to do with it. It can be a disaster, or it can be some good engine.
It can be a serious resource.
For me, I look at it as a very, very serious resource.
Well, there you go. This week, as usual, Waziri, CT goes around the country and around the continent, to each country every week, and he gets proverbs. This week, he'll tell you where we are, give you today's proverb, but then tell us what you think about it, right?
Sure.
Okay.
Let's start with the hint. This country is in East Africa, okay? That is hint number one. Hint number two, it leads this region in gender equality. It has the largest proportion of women in their parliament than any other in this region. Which country is this?
Of course, we know it's Rwanda.
Yes.
But my question for Rwanda is the following.
No, it is good.
It's good. It's a good thing.
No, it is a good thing.
But when you talk about this gender equality, I would want to see it all the way down.
Yes.
I don't see it in offices, in professions, in businesses, Because sometimes representation from the political level does not necessarily translate.
Well, it's not sufficient.
Yeah, it's not sufficient.
But
they're supposed to be advancing But even the affirmative action that even when I was in parliament, I didn't get that the women who are there now try to ensure that all the other cadres are covered.
Actually, the very thing you say is what is purposed. It is assumed, and I would also assume that if that level of representation exists, then it will cascade.
Yes, because of advocacy.
Yeah.
There you go.
You've said it.
Yeah.
That is what is hoped.
Absolutely.
That the agenda that pertains to women will be pushed, but if you have the numbers and that isn't being pushed, then we start with another story.
Okay, so let's go to the proverb. I want to talk about that proverb first, so you can tell us what you think, because we've got a huge issue before us to really go into, and I think there are very many things that we could share insights on. Let's go to the proverb first, and then we can come to that.
You can outdistance that which is running after you, but not what is running inside you.
Well, I think this is very apt, especially for where we are. Actually, everyone is trying to outpace the other in this country. And what we need to rely on is what is inside you. It's too much negativity. Too much of negative energy. Sometimes I like this proverb.
Yeah.
Because unless you rely on, it is so easy to give up and to get demoralized with all the outpacing. So ultimately, we have to depend on what is inside you.
That's interesting.
Yeah.
Because it's nice to see that we can have different perspectives to this. Because previously we said, you know what, you have to face that thing which is in you, face it, get over it, and then move. But then also there's an element of positivity of that which lies within you that you can use to then,
that
move
which can't be taken away.
There you go.
Yeah.
It's always interesting to get different perspectives. So, Waziri, as you know, as we get into this conversation, in October last year, SHA, the Social Health Authority, and then the Social Health Insurance Fund as a result of that came into being. I think there were more than teething problems at the beginning of all of this, which many would say would be expected. That when you start something new, that you would have challenges. But these challenges, 6 months later, still seem to be 3 months later, 4 months later, we still seem to be teething, and that tooth has not passed through the flesh. That there seem to be too many issues at the same time when it concerns accessing health by Kenyans. And so that's what some of the things that we want to look at today. Now, you being a senior advisor in the Council of Advisors to government, here we are saying, number one question, what is going on with SHA and why is it so difficult to get the basics? Pay, see a doctor, get it treated, go home. Which is what Kenyans essentially were assured was going to happen.
I like your first tripping. You've tripped by saying 6 months.
I came back. It looks like 6 years. But I came back and I said 4 months. I corrected myself. Yeah.
It's actually 3 months and 20 days. It's just 110 days. In 110 days, I'm very proud of this program. I'm extremely proud of this program. I'm extremely proud. And you remember, I was here with you in October.
Yes.
When this program started, and I said I'll come again and again, and I told you to keep my interview and ask me the questions. What I'm very happy with right now is that every other complaint I get is specific. Yeah. Meaning that the basic system has worked. And what we are dealing with now is exceptions. Yeah? Nothing made me happier than when I left cabinet and joined the team of advisors. First of all, the ability to choose what you want to do. And from day one, I said I want to focus on three things. I was very clear. I want to focus on health. And I want to focus on the youth, as I've just mentioned to you. And I want to focus on my third thing, which is jobs and incomes. Those three things, expanding economic opportunities. And it's not by accident. I mean, the health issue is a very emotive issue. Sometimes I wonder why I was not in this space for longer. It is very exciting, first of all. It's very fulfilling, and for me also it's very personal. In the year 2020, I spent during COVID, I spent 41 days in ICU, 41 days, and then 2021 I had an accident and I spent 4 months in a hospital ward. So for me, it's extremely personal that we fix. And the bulk of those 4 months was out of the country, outside this country, where systems do work. And I find myself so fortunate that within my lifetime, I have an opportunity of making healthcare in this country work the way it works in other countries, because we can do. So right now, every day that I wake up, I get questions from Kenyans, from this one, from that one, and the most important thing is, I tell them, don't tell me anything until you give me the ID number of that person, and I'm able to track back and see what was wrong with this particular case. In most cases, it is either a question of maybe there was some misinformation, some resistance by some hospitals and some professionals. That is there. I'm not denying that, or some cases where it becomes an opportunity to fix the system. But the most important thing is that right now we do not entertain any allegation, any complaints not accompanied by an ID number. And I want to say here, without a fear of contradiction, if you give me any case under SHA, under Taifa Care, with an ID number, and I'll be able to get back to you within 5 minutes and tell you this allegation is true.
Yeah.
This allegation is not true. This is what is not happening. So I cannot say that there's generic problems. There's many problems. In fact, I look forward. I've got some like 10 WhatsApp group I've created with members of parliament, with with doctors, with people there. I wake up at 6 a.m. Every morning to look for issues. I get to this morning. There's none. I'm so disappointed. There's only one case that was reported and found. It was posted by somebody at midnight, and by morning we at Kenyatta. It's about some child with some issue who it was claimed was not getting admitted. By 6 a.m. One of my colleagues, Dr. Lydiah, had confirmed that the issue has been sorted and is happy, because that's how we do it.
Okay.
We do it together.
So I hear you.
We co-create with the patient. We co-create with the doctors, with professionals. We co-create with media, with Kenyans, with everybody. Nothing makes me happier than when I wake up every morning, and I look forward to receiving an issue, especially an issue that we were not aware of.
Okay, so I want to go to what you said about, you're dealing with individual issues. So we're not talking about the system is lagging 40, 72 hours. People are not able to. So when we see, visual representation of somebody who said, look, I've paid my premiums. They've asked me to pay for 6 months up front, but then they're still not able to verify me in the system for me to get treatment. What would be happening in that particular situation?
Either hospital non-compliance, by the particular facility,
okay,
or something. I would be extremely keen, and I wish you could even open it up.
Okay, so let's go a little bit deeper into this. So last week we saw the video. I mean, the video went everywhere. You must have seen it, about the lady. She was holding her baby, and she was in the Afia house, offices, obviously, and they'd paid their premiums. But in order for her to now get the treatment for her baby, they told her that she had to wait, or that she had to come back in order for
you
it
mean
to
the
be
mothers who stormed the press conference?
In order for her to get the treatment. And this was not just your run-of-the-mill facility. This was the Kenyatta National Hospital.
I followed that case. Okay. I was actually out of the country. And the first thing I followed that case, when I saw it, I placed a call to our cabinet secretary, Dr. Deborah Braza, and I asked her, Waziri, what is this? I mean, and she told me that it's a legitimate system issue. So I was able to pick it up with our system people. It is true that our large hospitals, because a lot of focus has gone into what we call PHC, the primary health care, level 2, level 3, level 4. Our large hospitals, and this again is a vote of confidence in the system. The numbers in our level 5 and our level 6, like Kenyatta National Hospital, are right now overwhelming. Okay. Yeah. People are really going to facilities, and it's something that I find strange, because I compare with when there was a doctor strike, and when there was a doctor strike, numbers at our level 6 hospitals, KNH, KU, the referral hospital, Moi Teaching and Referral, they were down by 50%, and I was wondering, where are these Kenyans going? Because mortalities were not increasing. And now the reverse is happening. A lot of people are going to level 5s. A lot of people are going to level 6. A lot of people are trying to access the system.
Why?
I think it's a lot of people who are not covered. Remember, NHIF at its peak had 15 million Kenyans. So where are the other 40 million? And I'm talking about both principals and dependents. So where are the other people?
They were paying out of pocket.
They are paying out of pocket.
Yeah.
So if you find them now coming, it means something is good is happening. I always say that the nectar has not sent an invitation letter to the bees. The bees just happen. So a lot of people are getting confidence because of that payments are being done, and SHA is honoring the payment. That's why people are going to the hospitals. As a result of these numbers, there was a misalignment of one piece of technology. We call it the eClaim system. Another piece of technology called the Providers Portal. You have to remember that we are still a long way to implementing SHA the way it is supposed to be implemented.
Okay.
Let me say this. We are a work in progress. What we've done, we adopted a top-down approach, whereby we allowed all the facilities, 15,000 of them in the country, to be able to access our system from the back end. Yeah. And that has got its own problems. You know, I come from a technology background. When you allow so many people using all sorts of gadgets and devices, kabambe phone and whatever, it's what we call a heterogeneous infrastructure. All of them trying to, to access, the health system from the back end.
Yeah.
And so in this particular case, it was quickly discovered that something has to be changed in that particular structure for level 5 and level 6. That is why it was particularly a Kenyatta National Hospital issue. But as a result, we were able to take a remedial measure, which has now fixed all level 5s and all level 6s. Yeah? So, is it a good thing that it happened? No. Is it something to cry about? No, because we were able to run the rest on. And remember, what we are doing is unprecedented. Even by Western standards, to have one unified health system for the whole country is something that that's our. So we are a work in progress. I am not claiming perfection, but what I'm claiming is that every single opportunity, every single problem that happens becomes an opportunity for us to be able to fix the system, and ultimately, and you shall see, because I'm already getting calls. I'm getting calls from other countries. I'm getting calls from my friends, presidents of other countries in Africa, telling them we can't wait for you guys to get done with this thing. We want to copy it. The same way people come here.
Who's called you? I'm interested to know which countries have called you to ask you, can we...
I can tell you in confidence, Zimbabwe want to copy our system.
Okay.
Ghana want to copy our system. There's some Sierra Leone want to come and copy our system. Because it is unprecedented that a country of our economic status, a third world country, to have the courage to say we're gonna have a universal health care for all. And remember how many times we've tried this and failed. So in a nutshell, I want to say that one, I think we have done very well. 2, I think there are still some issues are still emerging. 3, whatever issues are emerging are becoming opportunities for us to fix the system. And 4, ultimately, when we do this, I am very, very certain that we'll have one of the best healthcare systems in Africa. By when? Becomes a question.
Right.
My target is by July, once we are done. There's something that I'll tell you later of now what ought to be done. I've told you that what we did was only turning the ignition key. It's not actually the implementation. The implementation has just started now. Yeah? So it can only get better. And we have started in one county called the county of Mombasa. Yeah? And I'll tell you what we are doing in Mombasa. So for people to be able to compare, the difference. And I'm sure that we are going to make every county a Mombasa by that 1st of July, which is my target.
Right.
Once there is so much that is not known about this system.
Okay.
And I'll be able to to take you about what is really happening in Mombasa, and maybe invite all of you. Yeah. And I want to do that in the first week of February to do a media tour in healthcare in Mombasa, a county where it's going to be and the population of Mombasa is like 1.2 million people. And Mombasa treats Mombasa hospitals, even before the SHA, was treating 1.8 million people, because people from Kilifi, people from Kwale, people from Taita Taveta, all those people, Tana River, all of them, we find them overrunning the healthcare system in Mombasa County. And that is why deliberately I chose Mombasa and said, let us have a best practice in Mombasa.
And see what's happening there.
Today, the governor of Mombasa, when he woke up this morning, for the hospitals which we have digitized, because we are doing end-to-end digitization. As we speak, 10 hospitals in Mombasa, you can't find a single paper.
Meaning it's digital?
Completely digitized. Yeah? I can tell you which doctor treated who. I can tell you how many minutes somebody was on the queue. The patient can know that if you are told that there's no drugs in the pharmacy, that's a lie. I can be able to track a doctor who goes to a government hospital in the morning and disappears to a private clinic in the afternoon. a patient by their phone, from their phone, can be able to tell you how many times they have visited. They can be able to see the status of all the claims that they have made. If someone makes a claim and it is paid for something, let's say surgery, and they quote a number, we are checking that claim against the license number of that particular doctor, ensuring that there's personal accountability and responsibility.
Okay.
Yeah.
We want to start looking into a little bit more of those details, even as we try to open up SHA and, the claims for, SHA is not working. A number of people saying, and it's interesting because some people have said, actually, I've been able to go in and it's working for me. In terms of having seamless interactions through and through, you've talked about it being a work in progress. Let's look at some of the other issues when we come back from this break in terms of, okay, so what happens with those hospitals who are owed money? What happens with those facilities who from the last system are owed money and they say, you know what, we can't accept this system to work for this patient because the government has not paid us what they owe us. What happens to the patients who show up there? Waziri Moses Kuria is here with us this morning and we're looking at the workings of SHA. One of the things that you have said in the past few minutes is that, it is a work in progress. And, as we get there, we'll get to a place where the system is seamless and we'll be able to really access healthcare in the manner in which universal healthcare is supposed to be provided. We do know that with SHA and SHIF, that there's certain services that your premiums pay for. There's certain services that government pays for directly, and that's just how it has been set up. We do know also that hospitals are owed money. They're entities, facilities that have been owed money for a very long period of time. How does this play out in terms of how patients are treated, or in this case, not treated, right? So if I present myself to a facility today that is owed money in the same health system by the government, the likelihood of them treating me as a patient then is reduced because they say, hang on a minute, you're in this system that already owes us money and for whatever reasons we've closed the taps. These are real life situations. It's not a makeup or Alice in Wonderland. They say we will not offer services because here is this money it's not been paid. Now, in this case, myself as the person who has shown up as a patient, I don't know what's happening between government and the facility. That's your business. So here I am and I've paid my premium, but I can't get treated. What are you advising this individual to do? Go to another facility, number one? Or are you saying, come back until we sort out our issues? What's happening with that particular issue?
No, granted, and it's not arguable that NHIF, the old NHIF, owed facilities money, and it's not little money. Mm-hmm. It's quite some money. Most of them, some of the claims are, of course, as you'd expect, are questionable, and Kenyans being Kenyans. In fact, part of the reason why we came up with this system is to stop that abuse that would see people, having all sort of, fictitious claims on NHIF and thereby diverting the resources that ought to go to all Kenyans. So that's one of the things to celebrate about the new system. Now, what did we do? Or what is the problem, first of all? The problem is that we would want to have all the money that are required to run this program. Right now, as we speak, only the three of you and 2.7 million other Kenyans are paying for 45 million Kenyans. I mean, it's a huge...
repeat those numbers again, please.
2.7 million people, PS3 people, are the ones paying for 45 million, for 54 million Kenyans.
Really?
Yeah.
There are some people who are not pay-slipped who are paying their premium.
500,000 of them.
So
half a million
are
out
they
of
additional?
16
Are they
million.
Additional to this 2.7
The
million?
2.7 million are the pay-slip people.
So then what we're actually looking at, if you say 500,000 people, give or take, so we're looking at 3.2 million people.
Yeah, carrying the burden of everybody else.
Okay.
Yeah.
So those who are not employed in formal employment, who are paying premiums currently towards towards SHIF, are 500,000.
Yes, and that's why because we deliberately, because we said because Kenyans are struggling with this new system to understand it, to register, to do many things, deliberately we went easy on enforcing that everybody must pay. And that time is running out, because for how long can the payslip people carry the burden of everybody? Remember, they are doing the same for housing.
The money will run out.
The money will run out, So we have really shown the financing, And it's what you're going to see as doing going forward. Because that's why we came up with this issue called means testing. Whereby, because you are already being tested by your salary. But that person there, who sometimes they have got more money than even the salaried people. Yeah, that everybody has to go do this means testing. Because what people forget about SHA is nothing new, but the old Harambee system, where I've got Harambee. So Mr. City Muga is going to be invited for a Harambee only by the people of his village because they know him. But now SHA is a national Harambee for everyone, for people you know and people who don't know, for people of your village and people of the farthest corner of this country. And in this Harambee, right now, the people who are contributing in this Harambee are only 2.7 million people. Before SHA, I was contributing 1,700. Today, I'm being charged 27,000 shillings. Yeah, per month. But I'm not complaining. Why? Because for me, it's a savings.
Okay.
Because if I compare with how much I was contributing to Harambees, it's a problem. Now, what I want is that I don't want everybody to contribute 27,000. But even if you bring 500,
even if you wanted it, it's not 400 possible because they don't.
Yeah, exactly. That's why you're saying to everyone according to their means.
Yes.
To everyone according to their blessings.
Yeah.
You know, and that's exactly where we need to go, so that all of us can be able to move together in that journey.
I want to go back. Sorry.
I'm coming back. So I want to give you the problem.
Okay.
First of all, so with the money that we're getting, and by the way, the income. With this new formula, this Harambee, even without the other people paying, compared to the old NHIF, the collections are already up by 400%.
Since when?
Since 1st of October.
Okay.
Compared to the month on month, how much we are collecting every month now, compared to how much we are collecting before. Okay.
Just sorry, I need you to break that down. I think it's important that we do so that we're not just throwing numbers out there, Waziri.
Yeah.
So we are saying that with the system that was in place, it was more than 10, but let's just say for 10 years.
Yeah.
So we're saying that with NHIF in 10 years and what was being collected, from the 1st of October, when we saw the shift to the new system, we saw an increase of 400%.
Of, let's say, we were in the region of more than double. Let me say that way.
Okay.
Just shy of more than double. What NHIF was collecting every month compared to what SHA is collecting every month.
Was that because more people were contributing, or was that because the amount of money, or was it because of the amount of money that people then had to contribute by virtue of the fact of the increment made a difference?
Absolutely, because it's Harambee.
Yeah.
This Harambee now starts saying, hey, how can Moses Kuria contribute the same amount to this Harambee with the city Muga?
So it's possible that the same people who are contributing NHIF for 10 years are the same people who are contributing to SHA, but the money increased
more or less
the government said
because
you
of the
need
means.
to have more money.
Yeah, because of the means. And now you can imagine now, once now we do this means testing even for the other guys and get everybody contributing in this national Harambee, you can imagine the system will be liquid. And even before we move to those people who are not contributing, by this double amount that we received from SHA compared to NHIF, we came up with something called RIFO. It's an accounting terminology. Last in, first out. We said, yes, I know I owe this hospital money. And I know that all debts of NHIF has automatically transitioned into SHA. Okay? But for what you are claiming under the new system, I will pay on the spot. Okay? So you clean up first what's happening today, then you start working backwards to the old debts. That's why today, even if we owe hospitals money, even if we are looking for the money to be able to settle the debts, even if we are trying to do the verification of those debts to separate the genuine ones from the fictitious ones, the cases of hospitals turning away patients have become almost negligible, less and less. Why? Because we say, look, search me. What you claimed yesterday or last month or whatever you've claimed since October, I have paid you. Meaning that I've demonstrated goodwill. Yeah, I've demonstrated goodwill that I have nothing to hide. And I'm telling you, yes, I know. I still acknowledge, I still owe you the debts of last year. But since I'm not accumulating new debts. So even this problem, again, go and do your survey out there. We have got less and less and less complaints about people being turned away because people have seen demonstrable confidence. Yeah, by hospitals to say that even if I am owed money that came from NHIF, at least on the new money, I'm able to to get sorted. And that's why you're saying, because all the claims are coming now through the system automatically. Yeah. Because claims are coming through the system, also the settlement is coming through the system. That's number one. Public hospitals and private hospitals. Now let's go back to public hospitals.
Yes.
For public hospitals, according to the patient who are visiting that particular facility, the new system, the new law came up with something called FIF, Facilities Improvement Fund. That money is given to a facility to improve themselves. Okay? And they retain that money at facility level. Something that was not happening at NHIF. And that money can be audited. It is automated. It is trackable. What we are doing now is that we are saying, because first of all, we have got two things that we are encouraging counties to do, especially county government. One is to say that zero takeout. It's a principle of zero takeout. That all the money generated from a particular facility are retained in that facility. Don't take it away.
For development
of that facility.
Because that was what I was going to ask you.
Absolutely.
I think this is one of the things that is vital here.
Yeah.
That one of the main issues we had is that, when we looked at the system, is that your lower level medical facilities, 2, 3, 4, were being more or less ignored by people because they wanted to go to your higher level facilities for a headache, a common cold, things like this. At the same time, your very serious interventions that needed to take place were slowed down because of lack of infrastructure, right?
Absolutely.
If we're looking at Kenyatta National Hospital now, just look at the cancer ward, for example. If you want to get a scan, you want to get an MRI and you're a cancer patient, the waiting line is ridiculous. So what happens is, what we're asking now is that people who travel, and this is the thing, people travel from Murang'a, come to Nairobi, people travel from Ombaso, come to Nairobi, people travel from all over the place, come to Nairobi, and then they put on a waiting list for 3 months to be able to get a head scan, for a medical intervention. Now, the question is here, whether there's a new system in place or not, the physical infrastructure in the facility still remains the same. So what is the transition then between the new system and ensuring that, okay, fine, this new system, swanky system in place, we can pay our premiums, get in line and do everything. But what is to guarantee that I'll walk into the facility and the ground really is actually ready to receive?
I like this question because what you've just described is exactly what was the vision of SHA. And you mentioned level 2, 3, 4, but you actually left out one level called level 0. Level 0 is a community health promoter.
Yes.
They are actually part of the infrastructure right now. They are part of the service delivery mechanism that for the last 2 years, they have visited 8 million homes. And they have referred people with diseases like hypertension, diabetes, etc., 350,000 of them into facilities. And now with the new system, your CHP, the CHP in my village is going to go to my mother and take the triage at home.
Yeah.
And from their gadgets, which you've given them gadgets, all the 110,000 CHPs, they will be able to refer my mother to the next level 2 hospital. And they will find level 2 hospital in the system waiting. Oh, are you Moses Kuria's mother? We have been waiting for you because we were told you are coming by CHP on the system, it's showing.
Yes.
And then from the level 2, some cases need to be referred to level 3. That's happening automatically now on the system. You can be able to track. And actually, the case of this morning in KNH is because it was auto-referred from a system, from a level 2 hospital, from a level 3 hospital. Before, there was no audit trail. You cannot tell whose word it is. You cannot, and therefore, people only believed that you can only get some good service from Kenyatta. That's why you find the higher levels, overwhelmed, because even kids, that's what we are calling the primary health care. It's supposed to be primary.
You know the other reason why they go?
Yeah.
Because when they go to the level 2, 3, 4, sometimes, and a lot of complaints came in that you can get a referral to a level 2, but that you go there and the infrastructure doesn't exist.
Absolutely.
Radiology, but there's no radiologist.
Hence why now we have this facility improvement fund, whereby every level 2 hospital will get money for itself. A level 3, a level 4. I can tell you, this hospital in a place called Kitimikai, how much money did it get? For how many patients? What did they do with the money? Let me give you an example. The governor of Mombasa has issued an executive order, governor of Mombasa, one of the most switched on governors in terms of healthcare. He said that he's given 3 very serious rulings, executive orders. One, if money comes to a facility, money does not leave the facility. That's rule number 1. Executive order number 2, 60% of that money will go towards buying medicines. And that has been automated in the system. Yeah? So we are going to have a lot of this issue of going to the hospital and you find that there's no medicine. Someone has to answer because we can see that money was deducted and money has gone to the medicine. The number 3 thing he has said, this year, starting from the 1st of January, he is not renewing the licenses of pharmacies that are operating outside hospitals. Because you know very well what those pharmacies were there for. You go to the hospital, there's no medicine, but you are told out there, in that particular one, you can be able to get the facility.
Is that really fair?
Yeah?
Is it really fair?
It is fair.
Because you're assuming that because a pharmacy is near a hospital, the only clients who would come to those facilities are probably referrals from the hospital. What if the pharmacies are near a hospital and the hospital is near residential areas?
You know, as well as the city talks about that. I mean, our spot check that we did last week in Mombasa, since you're talking about Mombasa, shows that patients go to hospitals and they are asked to go back. They're denied services because they are registered under SHA. As much as we want to heap praise on Mombasa, there are teething problems in that same county as well that need to be addressed.
And maybe not. That's why I said, give me the ID number. Because I can go to the system. That's a whole wonderful thing of having a system that is auditable. Because if you tell me this number, I'll tell you, yes, you are helping me. Because people refer these cases and they end up helping us. But I'll tell you something. The other wonderful thing about these facilities of level 2, level 3, and level 4 is that they are not the only people under SHA. The public hospitals. You get treated in the private hospitals in exactly the same way you'll be treated in the public hospitals. I mean, SHA does not discriminate. And that's the other wonderful thing. And so therefore, governors have smelled the coffee. They know if you don't improve these facilities, all the patients will be going to the private facilities. Because as a patient, you don't lose anything. Yeah? You choose to go to a Kibanda or Serena Hotel, and the price is the same, the treatment is the same. So this internal competition, this sibling competition between private facilities and public facilities is going to see, a mutual improvement. I have seen private hospitals also, they are now, waking up and they really want to be part of this success story because they know the government facilities are getting this facilities improvement fund. Yeah. The government hospitals know the patient can go to the private hospitals. Ultimately, the system will be self-correcting.
The picture you paint is the picture one wants to see. With regards to our healthcare system. In fact, when you're talking about public facilities, you talk about government facilities, that is where the vast majority of people would go to, because whatever you say, it's always been found to be affordable. There's something you mentioned which I don't quite understand, literally. The Facility Improvement Fund. If SHA is working, the patients who go there do not need to fork out any money.
Precisely.
Now, the money that then the health facilities would make, where would that come from?
It's come from you.
How? I have SHA.
You've paid a premium.
I've paid my premium. All I need to do is produce my card or show my ID.
Oh, okay, let me say it this way.
Yes.
Public hospitals.
Yes.
It's public let me make a statement.
Yes.
Level 2.
Yes.
Level 3.
Yes.
Nobody, level 4. Nobody goes to those hospitals and is asked to pay a penny as long as you're a SHA member.
Yes.
That's a statement of fact.
Okay.
For any disease.
Yes.
Okay? Subject to the tariff that is put there.
Yes.
I have a problem with this tariff sometimes also, because if you look at some of the benefits, for example, on the ICU and the HDU, and the few complaints now you are getting on the ICU and the HDU. If you are in Coast General Hospital, in ICU, you get you get covered for 3,940 shillings every day. Sometimes the cost is higher than that. Yeah, I would want to see more benefits going to the what we call the critical care. The ICU and the HDU.
Yeah.
I would want to see more money. Once we get these other 16 million people from the informal sector to come and help you, the payslip people, and we get more money, we are now forming a committee to review the benefits. The benefits are going to be reviewed commensurate with the availability of resources. That is why we want now to start this huge campaign of people to start to do the means testing and start paying for this, so that we get more money. Because if I add even by 50% the money available, maybe I'll be able to afford more benefits to the people in the ICU and the HDU. So I would say, and also of course, because of our fiscal situation, we are not getting money from the exchequer for the primary health care area as much as I would want to see. I would want Kenyans to continue paying taxes so that we can be able to fund the primary health care as well. So what I'm saying is that we have got nothing to be pretentious about. Where there are issues, there are issues. I think what we owe to Kenyans as a responsible government is where there are gaps. For example, I'm telling you, we have got obvious gaps on the ICU and the HDU. We are not covering the benefit as much as we want covered. I would want more money to go to cancer patients. I would want more money to go to, all the other chronic, cases. I would want the emergency and chronic care fund, ECCF, to be funded, because health is a priority. And it is one of the Article 43 rights in our Constitution. So I want to see more budget support, and I'm talking to our members of Parliament in terms of appropriating more money for our ECCF within this even the supplementary budget and the budget. I would want to see more money going into our commodities. What I'm saying is that as we are fixing systems, we're also going to fix the monies, and we are going to fix the monies from both ways. We are going to fix the monies by people in the informal sector also agreeing to pay to help the people in the formal sector. And I would want to see also the Parliament appropriate more money, and please talk to your members of Parliament
for it to come here.
To appropriate more money.
Yeah, Waziri, you'll be with us here for another hour, and opportunity for people to ask you ask you questions directly, because you said let's deal with those bugs if we can. The health system under SHA is our conversation for this hour, and the last hour as well. And we have been speaking with Senior Advisor Moses Kuria, the Council of Economic Advisors for Government. And this is an opportunity for you to ask those questions. There have been several questions. Social media has been rife with a lot of complaints and saying, you know what, this isn't working, the other is not working. Well, Waziri is here and he's happy to take those questions for me. Let me remind you what that number is 0719-012-600. 0719-012-600. Those issues that you've had, those complaints that you've had, let's talk about it this morning and get answers to some of those things and where you can go to get those sorted out. All right, we know what the proverb is for today, but let's remind ourselves about that, because Waziri believes that what you have inside will spur you on to go. No?
Yes. You can outdistance that which is running after you, but not what is running inside you.
But not what is running inside you.
Yes, if it's running outside and running beside you and behind you, and that you can outpace it. But if it's inside you, no.
Tough luck.
That will not be possible.
All right. Okay, so we continue looking at some of these issues, some questions to do, with SHA and the system, and whether it is working for Kenyans to the point whereby they're saying, okay, well, this is actually worth our dime. A question. Go ahead.
Yeah, and when we talk about matters to do with SHA and shift that does exist now, we talk about the real cases that we have. Let me just read. I was at the hospital, but I couldn't get services because the system was down. I fear that if the situation persists, this woman's condition, the child's condition will continue to worsen. Now, these are at Longisa AGC Tenwek Mission Hospitals. Hundreds of patients were left stranded and frustrated.
Longisa
and Tenwek. Now, this is another case of some medical facilities in Mombasa are accused of denying services to locals registered under the SHA scheme, leading to congestion in public hospitals. We will sit here and say SHA is working. But to that Kenyan who's seeking services right now, who has been denied opportunity to seek services, SHA is not working to them. There are teething problems, as you say, that need to be addressed. But how do we tell Kenyans who are seeking services right now and they're being asked to go back and tell them that SHA is working?
I'll tell you for sure, nobody is being turned away. I would be very much interested. And I'm willing to publish my number even publicly. I'm willing to publish my number. Because I know for a fact right now, maybe in the beginning, in October, in November, people are being turned away. Right now, and I'm challenging people to use the same channels and to reach me on that channel, or anyone for that matter, or CS for Health. Right now, at least on the very minimum from public hospitals, because at least those ones are within our control, nobody is being turned away. Nobody. From the private hospitals, maybe not. I would be very much interested to know. But all I'm saying, all I can say from where I am, in all fairness, is that as a matter of policy, and as a matter of what we know, as a matter of what is within our knowledge, what has been brought to our attention, nobody is being turned away. I would be very much interested to know about first of all, Tenwek Hospital is one of the hospitals where we have actually done some level of digitization. And the president was there some times back, and some few weeks back, in that particular hospital, which I know very well. And I know also of Longeza Hospital very well. I would be very much interested to know when exactly the system was down. I would be very much interested to know. I'm not saying the system could not be down. The system can get down. Every system, even any system, even Twitter sometimes can get down. Yeah, but I would be very much interested to know. All I'm saying is that I don't know what I can say from where I sit. All I can say is that where we are now, I am very much confident that the problems of system downtimes, the system of problems of availability, the problems of slow people getting OTPs when they are registering, or problems we encountered in October, in November, from December, and where we are now, I can only say, and I'm willing to Kenyans sometimes walikuwa wananisalimia wakati wa Gen Z. If they can salimia me now with accurate details of exactly I went to this hospital, I was turned back, I would be very, very much interested to know. It's also for our benefit.
If there are problems, as we're being told, and they've been there since we rolled out this particular system, has the ministry taken the time to collate the issues that keep coming up so that we can say these are the frequently noted problems, these are the frequently asked questions, these are the frequently experienced difficulties, so that a response to those issues can actually be provided?
You've provoked me. You've provoked me, because from today I'll also create a WhatsApp group for media people. Put it there. Yeah, put it there. I'll create one. I'll start with the three of you. And I'll also add people, all the media people from the other newsrooms. Yeah? So, because first of all, you know me, forget about being a government official. I'm a professional project manager of 3 decades. This is what I do. I used to do for a living. I manage systems, I implement systems, I manage projects, I manage complex projects, I have managed them locally, I've managed them internationally. So I'm not just speaking, I don't know, from a political angle, from a leadership angle, from a government angle. I'm looking at this just like any other system I've implemented for banks and all that kind of thing. And I'm very poor with generalities. I am extremely poor, let me admit, on generalities. But when it comes to specifics, you tell me this particular case, this particular patient, this particular hospital, this particular hour. I don't sleep.
You see why I mentioned what I've just mentioned is because with all these health facilities, given the burden that a new system will bring with it, and given the toll of that on the people who work there, if over time you understand that when people come in, because you may think it's a systems problem, but it is a problem that is being encountered by the patient who has actually come in, because this system is, if it's new to those in the health facility, it is also new to the care seeker.
Agreed. And those things, go down and down as
over
people,
time,
as people get to understand, as doctors get to understand.
Yes.
And what I'm saying is to accelerate that going down of the uncomfortableness. Is let's go specific.
Yes, we can. And that brings me.
I wish now I was hoping that my extra time here, we open the line and someone tells me, I went to this hospital and this one. So that I can right here call somebody in the system to check for me what this particular case is.
I could actually take that challenge.
We're going to open the lines in just a minute.
Just open the lines and let's get specific. I went to this hospital, I was denied, I was told if there's an answer, I'll give you the answer. If it is something wrong, I'll admit this is wrong. But ultimately, we have to build this together, me and you Kenyans.
All right, some of them from you.
I could actually take that challenge, I would not say their number, but we would take their ID number, and we find out, you make your calls, then we will give them feedback live here, because Yustofa Dachi says, since you've mentioned we give you your ID, could you please check for me what happened to my NHIF contribution? I'll give you their number. You find out what happened, just so we see how efficient that system is.
So in fact, what you could do, is that once you give me their number, mobile number, I'll get somebody from SHA to call them, and they give us feedback.
Okay. Yustofa Dachi.
And let me say the generic policy on the NHIF contribution. Or there was portability of all NHIF contribution up to the point they were expiring in NHIF. So if you had 5,000 shillings paid until X amount, until that is exhausted, there was no money to be lost on NHIF.
Okay.
As a general rule. I would want to have the number of that guy. He's going to be called by somebody from SHA. There's a lady called Hazel Koitaba. She's going to call that person, and I would be very much interested to know, about that particular case. And that's a patriotic Kenyan who is helping me to fix the system. That's what I'm mean.
Another question that I would ask you, Mheshimiwa, is today with SHA being there offering universal healthcare, and you said if we could go back to your earlier opening statement that the 41 days that you spent in hospital and about 4 months in the hospital ward as well goes to show, and the services that you are seeking outside the country today with SHA being in place and the 27,000 shillings that you have been contributing and deducted. Today, Moses Kuria, would you seek health services from Kenyatta National Hospital and Asha?
When we are done with this, when we get more money, when we get all those other 16 million people paying, so that you can even add the ICU, when you can add the HDU, when you can add the benefit, it will be possible. Not just for me, but for every Kenyan. Not just for me, but for every Kenyan. So let's get everybody together. I'm just saying this also, the fact that 2.7 million people paying for 54 million people. We are heading dangerously to some cliff, which I think something has to be done. And because we've said it's a harambe for everyone, please, when we start saying everybody has to pay Atakamani 500, wacha tusisikie again. It is media which is now again telling Kenyans munafinywa. We've said that this one was kama ni kufinywa, already the payslip people are being finywa. I feel for them. Me being one of them. I feel for the payslip people. They are paying for the NSSF contribution have gone up. We have read the same payslip. Is it something bad? No, because we can't continue as a country which does not have a savings culture. The same payslip we read for the housing levy. The same payslip now we are reading for SHA. Now it's about time for the other people. And most of those people, they have more money than me and you.
Okay.
The people in the informal sector, they have more money than me and you. It is time for all of us now, media, everybody, to say, when we ask for a meal, everybody will eat. But when it comes to pay, let also everybody, open up their wallet and pay, so that everybody can be able to go to Kenyatta in the same way I would go to a foreign hospital.
What's the amount of money that somebody pays as a premium for SHA today?
Payslip or non-payslip?
Non-payslip.
Non-payslip. It is according to their means. You do some means testing. There's an algorithm there, and then it returns a value and tells you this amount you are supposed to pay every month or every year.
So I have to go into the system and see
As you
now.
register.
As I register,
Yeah.
I get onto the system and it tells me based on the information that I put into it.
You
it's
should
telling
pay
me that per month I will
5,000,
pay 5,000 or I pay 1,000
100 or 500
or something like
or
that.
400.
So it gives me
or it
based on,
tells you are completely indigent. What you call indigent, that's government or somebody has to pay for you.
Yeah.
That also is possible. And counties are stepping up. Murang'a County, as we speak, has given us a check for 37,000 citizens of Murang'a who
are indigent.
Who are indigent after they have done the means testing. And the governor Kangata has written a check for to cover that 7,000 according to the means, because we have to help each other. Governor of Mombasa right now, since we started this exercise in Mombasa, now I've just received figures. Mombasa, in terms of percentage, Mombasa is now number 2 nationally, just down from Kirinyaga at 27.something%. And Governor of Mombasa is sending out these community health promoters door to door. And today we are starting even another exercise where we're going even to the schools and calling the parents there so they can register even their children and dependents there, so that ultimately people start paying. And the Governor of Mombasa and members of parliament, I've met all of them. We have agreed that MP will go back to the CDF, governor will go back to his kitty and look at these indigents and pay for them. Now, another interesting thing, even for the other people who are not indigent, we are talking to the banks to do something called insurance premium financing, whereby some of them are, even some of our telcos, like Safari committees have come up with programs to enable these Kenyans to pay even by the day.
So how quickly?
For the border people.
Sure. Yeah. So how quickly, let's say, I'm onto the system, and this is based off of a number of questions from people in terms of, because one of the big issues here with a lot of questions that we're seeing is the waiting time to be able to then get logged onto the system and start to access. Because sadly, but is the reality that people then go onto the system when there is a need for them to access medical care, right? And I know I need to go to hospital, right? And I know that I'm going to be covered by SHA, but I have not registered for whatever reason. Obviously, if I'm non-salaried, right? And I now get onto the system. The algorithm does what algorithms do, and I now know that I need to pay 1,000 shillings per month in order for me to access this because of the information that I've put in. What is the lead time between now me getting this 1,000 shillings and let's say now by the special grace of God I have 12,000 bob, so I pay for a year up front, right? What is the lead time between now that payment and now me being able to walk and say I need to see a doctor?
That is a very good question because. I think you are the unconscious brand ambassador for SHA for the new system. Because under NHIF, we are waiting for 3 months. Sometimes I think even more than 3 months. Under SHA, it's instantaneous. There and then. There's no waiting time. What a tremendous jump. What a tremendous jump that before you had to wait. Now, we have open door for everybody. You register here, you get treated there. Now, in Mombasa, the 51 public hospitals in Mombasa, all of them, we have got a registration desk inside the hospital. And this week, the 320 private hospitals in Mombasa, we are rolling out even these CHPs to go and register you there. You get registered, you get service there, and then, what an improvement.
I believe it is. Most people who go to hospital don't go with complications that may necessarily require surgery or may require some intensive care.
Yeah.
They simply need to be attended to and they'll go back home. Now, how do we get the citizenry to understand what to do when they have an issue when it comes to receiving the services that they're supposed to once they have registered with this new system? Because that really seems to be, in my mind, the heart of the matter. Because we're saying there are problems and it equals system is not working. Okay, we've understood. At the same time, we do get reports of people who say, but the system is working. I know because I have done A, B, C, D. So, to balance this, I'm going back to a question I'd asked earlier about the frequently
ask a question.
Yes, and the frequently reported issues. Now, how do we ensure that healthcare providers understand in detail how to respond to this? Because instead of people going to the social media to complain, you're complaining about a situation in a hospital of health facility where you are. That problem could have been solved right there and then. what happens so that somebody now has to complain outside? So the whole world know that.
Yeah, that's a very good question, because that's a very, very good question which I've been asking myself. I have to be honest with you, that why is our doctor, why is that doctor there, why is that clinic officer, why is that nurse not being the first ambassador of education, the first teacher to train the people? And that is exactly what we are training now. We are engaging more and more with the professionals, with the practitioners, because this health is a very personal, emotive issue. It's not a community issue. It is you as a person. And two, health is very experiential. Yeah. Until you experience it yourself, until you go there yourself, it's not a story you can be told. It's not something that you can outsource to somebody else. So I cannot get sick and I send Mr. Muga to the hospital on my behalf. It cannot happen like that. It is experiential. So the minute we look at the touch points, and that is why this digitization of the facilities is very, very important. That's why I'm putting no stops to ensure that we digitize our facilities. You know what does digitization do? It provides evidence. Because right now we have got so many things there. Because people are writing on these scribbled small pieces of paper. So we have no evidence of who was told what.
Is it difficult to have a help desk? Help desk.
No, we have a national help desk. Yeah?
No.
Sure.
At the health,
at the health
every health facility, so that they know if you have an issue that you have a problem with, that's where you go.
And by the way, SHA has got facilities in all the government has got a desk in all the facilities. They do. We do have.
So what then one can expect is that the problems that we keep hearing of will not just, they will keep reducing over time.
I like this guy, what he has done. He has gone to Ombaso to the facilities. Okay.
Yes.
Yeah. And that's what I'm saying. I think we need to do together as government and media to do. Because I was talking to a friend of mine called Nicholas over Christmas, and he's part of the team that is delivering this. So he was going to Vihiga, to his home county, in a place called Okoh. So we were talking when he was driving on the way. So we agreed that he's going to stop everywhere along the way from Nairobi to Okoh, and see how start to get some actual feel. Me, I'm a ground person. I'm a ground person. I like to listen to the ground. So he told me something funny. He told me whether it is something scientific, because the amount of noise is inversely proportional to the distance from Nairobi.
The further you are from Nairobi,
the more people appreciate the system. You know, it shocked me. You know, I'm in the village. My mother is saying, "Oh my God, I've been." The other day we went to the governor to Coast General Hospital. Somebody who has paid 7,000 shillings had a bill of 1.2 million paid for. 1.2 million. 1.2 million paid for there. So even what we are calling complaints, really, and that's why I didn't want to have this system of actual verification. The people, when they are experiencing, the real beneficiary, the people who are interacting the system, especially our people within the rural areas, I don't know, they do tend to appreciate the system. And I think right now, social media is a very good thing. There's a lot of these conversations happening on social media. We just want this now noise to be backed up by actual specific evidence.
So you're saying that there's a danger now, for example, that folks may be joining a particular bandwagon and saying SHA is not working, even if it is. Is that what you're saying?
For those people who can afford, they are telling people who cannot afford normal health care that SHA is not working. You know, and I will say this for my own region where I come from, Mount Kenya region. When I was doing this outreach in the communities, and you know, right now there's a lot of negative politics within that particular region. So I told them, even if you are saying Ruto must go, join SHA so you'll be healthy. You live long to say Ruto must go. Because if you die, you not even be there to see Ruto go. You know, there's a lot of
what benefit
mixed up with this whole thing.
On the same argument, of what benefit would it be for somebody to say a health system is not working when it is?
It is.
Why would I say that something that I go to a medical?
Ask me.
No, seriously, why would I walk into a medical facility?
Not you.
And if anybody, for
I'm asking not you, not that anybody.
And
it's not the actual patient.
Got
The
it.
problem is somebody else saying.
Okay, so so what are you saying here is that
Somebody
people,
discouraging people.
And these are not
You
real people?
A patient who cannot afford.
and these are not real people who complain about the fact that
No,
their
some people are. I'm dividing between two
that their
categories.
grandmother of 80-something years old
80
tried
mother,
to register
80
on the system and it wasn't working.
80-year-old mother would complain genuinely.
Yes.
I was in Mombasa, and there was this lady. She told me she was 83. I have that recording. I can even send you that recording. She said, this system of yours of star 147, how do you expect me as a grandmother or it is something to know how to interact with the system? And we told her, this is exactly why we are sending there. Now we have got a new way. We are sending the community health promoters inside the homes so that they can be able to, because we have to be realistic of the country that we live in. We cannot be pretentious about it, Still, some people cannot, be able to use star 147 hash to be able to register. So it is something genuine. And some people will complain genuine because either they are not well equipped to be able to access the service, and that's why I'm now going through that other loop of helping them where they are, recognizing who they are. It is not a crime not to be able to use a mobile device.
Or to even have one.
Okay.
Yeah? Or even not have one.
Right. Okay.
That's why we're now going now the other loop to send people to help even those people who need some assistance. So there's those genuine cases of either people are not equipped, people are not trained, people are not being communicated to, or maybe sometimes system gets lapses here and there. But then I'm also talking about this other cadre of people who discourage genuine people from using the system. Them, they can be able to afford healthcare by other means. I think that is.
Let's take a question before we go to the break.
Yeah. You've just mentioned that there's someone who had paid 7,000, but the bill was 1.2 and SHA paid for that.
Yes.
But I want to take you to another question that has just been asked here by one of our listeners who says there is someone whose wife's bill was 370,000 shillings. SHA ikalipa 120,000 shillings. The balance is 250. The question now is, what is the criteria under SHA when it comes to settling these medical bills?
First of all, and maybe this is why I need also to build that WhatsApp group with the media people, because you play a very important role in interaction with the users, so that I can be able to share with you the tariff. The tariff is published. You can find it in the website of SHA, of Ministry of Health. The tariff is a public thing. It was published in the Kenya Gazette. It tells you what is possible and what is possible. And I don't really want to ask Kenyans again and again, especially in the media, because we're interacting, to go through this tariff to see. When I tell you 3,940 for ICU, so then you know that is ICU. When I say what you are paying for surgery, when you are paying for maternity and for all these things, then you are able to verify there. This particular case I cannot answer, because maybe it's an ICU case, maybe it's a HDU case, is it a general ward case, is it an inpatient, what is it? There are so many other things there which the details can only be found within, one, what is the clinical case, and two, what is the evidence. Number two, that particular hospital, once we digitize that particular hospital, you'll be able to see, to answer that question even yourself, because I'll be able to say, I came on this date, I registered, I went to nurse X, she took 3 minutes with me, took me to a doctor, took me 7 minutes, I was referred to the lab, it took me 4 minutes, these are my lab results. I then went to the pharmacy for the drugs that have been prescribed for me. So that whole trail is going to be shown. Right now, I'm sure that information, even for that patient, is between one scribbled piece of paper from one person to the other person, making it, even for me, I have to now make the call, and I would want to have the details of that person. But even from where it is now, I can't tell, because there are so many other parameters there. For example, what I suspect for that patient, you said they had to pay how many?
370,000.
And they were paid for
120,000.
120,000. I think that is somebody who was in ICU or HDU for like 30 days.
But you say
most likely.
You see Moses,
because that gap there of what we paid and what the patient was charged, and I'm making just an intelligent guess, because I need to delve into this case, and I will delve into this case. That gap there of that funding is what I'm calling the emergency and chronic care fund, which really badly needs to be funded, and that's a gap we're having. But for general things, if somebody went for a general illness, even an inpatient in a level 2, in a level 3, in a level 4, Hakuna kitu kama hiyo.
Waziri, the discussion that we're having has to continue for a simple reason. Huh?
Yes.
We have examples of people who are in that system and have had bills paid.
Yes.
In that same breath, we have people who keep saying they have these problems that keep coming up. Now, the categorization, which is represented by what we've just said, there is a lot about this system that is actually not understood.
Correct. And I think, City, I think you summarized that issue very well.
Yes.
Okay.
I know
You summarized very well because you said, why would it have to come to Moses Kuria or to Spice FM when there is a doctor, a facility there which can be able to
answer the question,
which can be able to handle that issue on the first line?
Yes.
I think that for me that's a profound point. That you've
Waziri,
taken.
I have a friend who died at Coast General Hospital.
Sorry for that.
No, it was a person living with disabilities, okay? All that he paid was 6,000 shillings because he had an arrears of what was supposed to be paid. When he was unwell, that was paid. His bill came to 260,000. It was paid.
Yes.
All of it
Yes.
was paid. So I know for a fact that from the example of my friend, SHA works. But there are many other hiccups. Now, unfortunately, these hiccups dominate the conversation. And so one gets the impression that this entire system is not working. And yet you keep hearing stories of people who tell you it is working because it has worked for them.
Yeah, absolutely. I think for me, first of all, health is largely a default function. And this is a conversation I'm going to have with the governors. Yeah. About the first line of patient support. The first line of patient support cannot be SHA head office, because in any case, first of all, this is a devolved function. Our primary relationship should be with the counties and the hospital.
We do have some
and by the way, something amazing we are doing in Mombasa. National level, we have got another parastatal that was created called the Digital Health Authority,
right,
which is owning all the systems and providing the support. The governor of Mombasa has done some unprecedented thing. We are devolving that Digital Health Authority within the Department of Health of County of Mombasa. We are setting up a Digital Health Authority there, so that issues can be with the whole county can have somewhere they are doing it. So again, when I say it is still work in progress, because the minute for 7 counties, and maybe this is a profound pointer that I'm taking from City from this interview. Maybe that's something that we first of all roll out, irrespective of the system, roll out in all the counties, so that at least counties we have some teams within every county, because it is time for governance. It's time for counties to take ownership of health.
Let's take some questions that are coming in.
Health is a devolved function.
Of course. Let's take some questions that are coming in. You can answer these directly. We'll hear first of all from Zachary in Kakamega. Zachary, good morning.
Good morning. How are you?
Very well, thank you. How are you doing?
I'm very fine. Good morning, Honorable Kuria.
Okay.
Yes, my question, I will break it down from the issue of the means testing. I am not sure whether Honorable Kuria is sure that we have the relevant data to operationalize the means testing instrument. And then 2, about the system. Previously we had an HIF, and we patients never had issues to all systems. So I don't think they should be reducing us to the issue of discussing systems. We should pay up, go to a facility, get treated. The stories about system not working, that should be an issue to be sorted by the government. And about my experience, last year I was admitted, and for the first time, I was told to pay for the bed. I am fully paid up, member of, I can call it NHIF, but I registered on SHA. So I think Honorable Kuria and the people implementing that system should acknowledge that even though they imagine the system is working, there are challenges. Let them not rubbish our complaints. There are challenges, we are going through them. They are likely to happen, but we need them sorted out and remove us from the issue of discussing systems. We need services. Thank you, and that's good day.
Thank you very much for those questions. in terms of what the complaint was, in terms of now saying, if there's a system problem, folks are saying that should not be their problem. They should come in and be able to get services. Yes?
What is the actual complaint?
Well,
what he said was the complaint.
And I've got the governor of Mombasa here. He's asking what's the number he can call because he also wants to give his feedback.
The number is 0719012600. We'll take another call and take a quick break and come back. Waziri Moses Kuria is in the studio and he's taking questions from you. We'll take another call. Hello, good morning.
Good morning.
Yes, you have a question for Waziri this morning on SHA, Shif?
Actually, I just have to correct Waziri for a bit. The level 2 hospital that he is talking about do not have anything. You can go there, you are just given Panadol, no even testing. They don't have any facility. So when you use this system called SHA, payment is correct. You are paying and it accepts immediately. The problem is now to get the services. That is where there is a problem. So the Waziri should come to the ground and help us to access the system. Today, you cannot access the services without paying. Like for me, I'm paying 850. But before paying the amount, I cannot access the system, the services. So, paying the hospital so that the hospital can get drugs and facilities squarely lie with the government. So let the government do their part so that the citizen can access the services. If I go to hospital and get good services, there is no day I'll complain about the services. That is the only thing that we are requesting.
Okay, so maybe now Waziri can get to that before we take a couple more questions, isn't it?
I think that gentleman is right. The owners will be on facilities. It will be on counties. And that one, they cannot do back passing. They cannot pass the back. And once we are done with what we are doing, in the next few months that we are doing this, I think counties need to start preparing on how to handle this because they will have now there will be no national government to blame. It will be squarely on them. And Monanchi will be asked, you've been receiving money from this facility improvement fund. How much of my facility have you improved? So two things will happen. There people will be very unhappy with them. Yeah? And I'm saying this to all counties. Or two, those patients will migrate to private hospitals because private hospitals, that gentleman, if he goes to a private hospital, he will be treated in exactly the same way as a public hospital. So right now, it's okay, everything is on the national government, but as soon as we are done with what we are doing and we finish this particular rollout and ensure the system is working, now the focus, I cannot speak for county government. I am saying it is up to every county government to smell the coffee.
And it shouldn't be under the same umbrella since SHA right now. We know that health is devolved. However, there's an element of control that still comes from central government in SHA.
In terms of?
I mean, what are we talking about now? The system.
No, I'm saying once we're done with that bit, once we're done with the project, that's why I want, for 31st of January, national government to be out of all hospitals. Yeah, I want them out. So that now we say, look, don't come to me now anymore. Look for your governor. Yeah, because I've done what I need to do. Yeah, so I think, and this is something that we want to talk to governors, and we'll continue having this conversation with Council of Governors and all governors to say, let everybody do their part. I am liable for what is for national government.
Okay.
But again, the patient is right. Even in that case, they will not care whether it is national government or county government.
Not their problem.
But ultimately, somebody has to take accountability. Yeah.
Okay.
Remember, some of the facilities are not also faith-based, and I'm saying this to our faith-based organizations. Even now, we need to work together. Private hospitals as well. This is not a situation whereby now somebody can say that mine is okay. The other one is want to blame. This is a situation whereby all of us have to work together. But in terms of that gentleman, in terms of level 2 hospitals, yes. And my assurance to him is that is exactly why SHA came.
Okay.
We have got some money dedicated for that particular facility.
Let's take some more questions, shall we? Hello, good morning.
Morning.
Good morning. Tell us your name and where you're calling from, please.
My name is Dr. Kimani. I'm calling from Lydiah.
What's your question for Waziri this morning?
I wanted to inform the Honorable Kuria that SHA still does not have dental cover. Previously, NHIF ilikuwa inalipia watu kung'olewa meno. SHA saizi imewachilia watu.
Okay.
I agreed.
Solution.
Dental. More money.
Yes.
More money.
More money is needed from more Kenyans.
More money is needed for more Kenyans to be able to put this national harambee. Hii harambee hata kama ni ile unajua kwa harambee kuna ile pesa tunasema you don't announce the money. Unasema na ingine mingi na mingi hata kama ni hiyo kidogo. Hata kama ni ile haitangazwi. Let all of us dental needs to be covered.
So as more money comes in, essentially
More
now what you are saying is that more services will be offered and it will be announced that now dental is available on the SHA.
Dr. Patrick Amoda, our Director General for Health, this week is setting up a committee to review the benefit because we will review the benefit commensurate with the money that is coming. Okay. This is our harambee. It is for all of us.
More questions coming in. Hello, good morning.
Good morning.
Hello, tell us your name and where you're calling from. Your question for Waziri?
My name is Jeanette, and I'm calling from upstate New York. As a Kenyan living overseas, when I watch this, it seems incredibly concerning that nobody is really explaining why the system is not digitized. It seems like part of it is, to say the least, slightly disorganized. And I don't understand how you can roll out a program without actually implementing systems and testing them before rolling them out. Thank you.
All right, thank you for that, Jeanette.
The system as disorganized as Obamacare. That it is in New York.
She's Kenyan.
Yes, 10 years later, I benchmark with the US and the UK. In the US, despite all the years of Obamacare, because it's still Obamacare that is at work in the US, there's still a lot of disorganization. There's no country with more, all those years. Forget about us with the 110 days.
Excuse me. I'm not attacking you. I respect you. I respect your office. And I think that it's peculiar that we're not able to come together with all the people who are so gifted and so intelligent and create a system that actually works.
And what I'm telling you, my sister, is that the system we are creating within the next few months is going to be much, much more superior than the US system.
But why is it that you create a system that's not working?
How is it that the US
and
created
you
a
had
system?
one that was working.
How is it that you are accusing us of disorganization within 110 days?
Why are you being
and America has had a system that is still leaking, that is still having a lot of complaints a whole 12 years down the line? Because these systems are works in progress. And it's not easy to have a system that is for the whole country, all 54 million people. I know to many people this is not something that should be done by a developing country like Kenya. But I'm a very proud Kenyan that even within our means and within our economic status, we are able to roll out a system.
So let's Jeanette, can we hear, if you do, it's a question that you have that we can get an answer for, and then we can move.
Oh, thank you. I appreciate that. I think the question would be, why isn't there a call center for people to call? Instead of running from one place to the next, complaint here, complaint there, like, pull it together, make it easy for people to get support, and just get the show on the road. It's just like we're just going round in circles.
Okay, so there's a question.
Thank you very much.
Thank you very much for that, Jeanette. Maybe we can get an answer for that in terms of one central place where folks can ask questions and then they can get answers for us.
I think we have got our national call center at SHA. Admittedly, we need to do more of public communication for people to know that this is where I call. Ultimately, I don't believe that is a solution because I'll go back to City Muga's position that most of these issues need to be handled at the lower levels, at the facilities levels. Putting counties as a layer also of, because health being a devolved function, that counties need to also set up their response centers, down there, and we are piloting that with the county of Mombasa. So let me say this, that I see four major issues that need to be tackled. One, of course, is counties have to improve facilities. That is what is really coming out. Second thing is that technology has to work, and that is what I am very comfortable with, because that is directly within my control as national government, what you can be able to do. The other one is clinical. I mean, doctors have to use a system in the right way to give the best treatment to people. But ultimately, it is on issue management.
Okay.
And that is where I think we have a problem, that we need to put in layers that are able to, for people to know where they need to go to when they have a problem. And so this is also for the benefit of everybody, all the stakeholders, because once you have got a response, why I'm confident and why I appear like I'm not taking these issues is because at least I know what is happening.
Okay.
I wouldn't say that everybody else would know what is happening. So ultimately, when people know where they need to complain, then I think
then it makes it easier.
We are able to separate the real issues from the presumed issues.
Let's take a few more calls
overall,
as we can.
Overall, 110 days. Now in the national health system of the UK, in the National Health Service, NHS, we have got waiting queues of up to 4 months. I dare say like our M-Pesa. And I was here when we started.
Yeah.
And I said from M-Pesa, the next big record, Kenya is going to keep us on this SHA.
Okay, let's take a few more questions. I think it's important that we hear from folks. Hello, good morning. Can you tell us where you're calling from and your name? Hello, good morning. Hello? Okay. All right, let's take some more of those calls. It's 0719012600. Some of those dropped off as we wait to hear back from you. So, I mean, here, and I think these are some of the things that you've just given kind of like a recap to, Waziri. So, some of those calls coming back, 0719012600, looking at SHA and how it can actually work. One of the big ticket items is that centralized call. Dennis, there were some questions coming from you.
Yeah, there are questions that are coming from those who are watching us on YouTube, and one of the key areas that have been asked is before the rollout of SHA, was there a pilot program to make sure that all these teething problems have been addressed? Because there is a feeling that even at the point that we were launching it, we did not sit back to roll it out and look at the teething problems that we're now dealing with.
By the way, I was there on the 1st of October. It was chaos. It was chaos. 1st of November, less chaos. 1st of December, much less chaos. Today, specific isolated cases here and there. I wonder what we'll be saying in July, for example. I wonder what we'll be saying in July and all that kind of thing. And that's how good it is. This is not a small company. It's a Kenya of population of 54 million people. The county of Mombasa only, after we're done digitizing by that 1st of January, is the same population as Estonia. It's the same population as Bahrain. If you take their 1.2 million population, you rank it according to our population. I'm saying it's possible that the county of Mombasa will leapfrog over Estonia in terms of the number of people receiving medical services, healthcare digitally. If it was a country on its own, it would have a world record, the county of Mombasa. Now imagine now when we make this across to all the 47 counties. A country of 54 million people. I'm really watching this, and I want the next time you get your correspondence in the UK and they tell you the kind of chaos we have there. I think I know ideally, because I'm a systems person, I know it is possible, it is the right thing to do a pilot program, to do a pilot and something like that. But I'm telling you, that was not something that was not under our consideration.
Let's take another question. Tell us your name and where you're calling in from. Good morning.
Good morning.
Yes.
This is Murunga Masinde.
Yes.
I'm a retired teacher.
What's your question for Waziri this morning?
My question is, when you have retired, you don't get the pay slip. I don't know how much I'm contributing or I'm not contributing. How do I understand even if I've registered, how do I understand what I'm paying there? Or that's my problem. You have retired. You don't get a pay slip. You want to know what is being deducted or you are not being deducted for the SHA.
Okay. Hold that question, Waziri. Thank you much for your question. And let's take another one. Hello, good morning. Hello, good morning.
Good morning.
Good morning. Tell us your name and where you're calling in from and your question for Waziri.
My name is Boit. I'm calling from Nakuru. Niko na swali kwa Waziri. Ama maoni. Mine is on the means testing, Waziri.
Yes.
When you go through the process, the means testing places you on a very expensive premium rate. Where can one go for review or appeal for this? Because it's a serious issue. Some of us are not insured because of that.
Okay.
That's a very good question.
That's a good question.
Let's go to the teacher
Can we hold on to that one and take one more and then you can answer the three in one shot? Is that okay, Waziri?
Yeah.
All right. One more question. Hello, good morning. Could you tell us your name and where you're calling from?
My name is Biwot. I'm calling from Nairobi.
Yes, Biwot.
I would like maybe just to give a comment because I think the problem is not really SHA. The problem with this country is tenders. Why am I saying tenders? Because people would want to create an issue so that they create a tender to consume something. I leave that comment at that because Waziri understands. That's why you see people, those who are against the tender, saying so much about SHA, those who are pro-tender, defending it so much despite it not working properly.
All right.
So, like some of us who are in Juakali, no one is really telling you how to contribute, what benefits you're getting, how is it going to support my family and I. But every day we are being told it's working. It's working. But NHIF was working for me. I was in Juakali. It worked for many years. Then one day I was told it's no longer working. So you see, for me, they wrong-footed me.
All right. Thanks for those questions. Biwot on that comment. Let's allow Waziri to...
Let's start with Biwot. You see, now that is Biwot, now I need him to pay.
Okay.
Yeah, that Juakali guy is the one who is making me pay myself alone. But Biwot is also raising a very pertinent issue that once he pays, I don't think Biwot has a problem paying. He also wants to know what are the benefits he is able to get. Retired teacher is now just like informal sector people. You know, so he needs to go there in the system, do the means testing like anybody else, and the means testing will tell him. So this, as long as you are not on pay slip, the system does not know whether you are retired or where you are working or not. So it treats you just like any other person who is in the informal sector. So I want to ask Mr. Retired Teacher to go and do the means testing so that he can know what he contributes. The gentleman from Nakuru on the means testing complains the complaint system for means testing. We have got our SHA hotline, our SHA, and I think the point out, the takeout here is that we need to go out again and again and again, and you'll see us coming to media.
Yeah,
you'll see us coming to media now to say not about SHA is working or not working.
Yeah,
but to tell Kenyans if you have a problem, this is how you complain.
Okay.
Yeah.
Yeah.
It is a touch point of complaints
that
are admittedly an issue.
Okay.
Yeah. I think even from listening to Kenyans, it's not, nobody's saying SHA is not working. People are just saying, when I have something, either out of ignorance or out of genuine concern, I don't know where to go.
And I think that's why it's important to do this. And so I'm going to do something this morning uncharacteristically.
Yes.
Because we have too many questions and we have you here.
Yeah.
And we're going to ask for some 20 more minutes of your time after the top of the hour. I would like you to hear what Kenyans are asking and give them answers for them while they're here.
You know,
Can we do that? I
was coming here for an hour.
You were coming here for breakfast. We're going to offer you lunch and dinner.
You make it like it's going to be lunch here.
We don't know when we'll see you next, so let's take advantage while we have you, isn't
Those
it?
people who are asking questions are the ones who pay my salary.
There you go. All right. Our conversations continue this morning. We have been in the room for record-breaking hours with Waziri Moses Kuria, and we've been talking about, things to do with SHA, and there are questions coming from people, and it's a responsibility to answer them and at least put Kenyans at rest. All right. So many calls coming in this morning. Questions for Waziri. Let's start taking those this morning. Hello. Good morning. Tell us your name and where you're calling from. Hello. Hello, good morning. All right. Hello, yes. Can you hear us? Good morning.
Hello, good morning. I'm calling from Naivasha, Karagita.
Yes.
Okay, my comment is that I'm a bike rider. Can I talk in Swahili?
I beg your pardon?
Okay. The problem is that
Okay, I don't think we can hear you very clearly. Can you come again with the question?
Kenya, we are going under best journey simply because wakati wa uhuru sisi tulikuwa tunapata bibi zetu.
Endelea tafadhali.
Okay, go ahead.
Okay, wakati wa uhuru mimi niko na bibi na mtoto na mpengo alijifungua bure na nikipata free service, but now it's a bit challenging for us simply because karibu tunaambia about SHA na tuina haitusaidia pia tu na advertise that ukijaribu kuangalia kama sahizi mzangu ndio kufungua tena I have to pay 8,000 yote wakati wa uhuru ilikuwa bure, so things are going tough in Kenya and I wonder why mtu ana comment, mtu anasema suggestion yake alafu napata mkubwa anasikia vibaya.
Do you have a problem? Is there
because they're the ones who feel the pain in ground and sile napitia haya magumu au juu hajui nimepitia at least sisi tuko ground ndio sitani kama shaenda hospitali ya chini.
Okay. All right.
Mimi nimetoka hivi ndio napitia shida kila siku kwa ground. Kwa wakati mtu akikuanza kwenda hospitali na pita ukijaribu kulipa unaleta yote that there's no service you're getting. So
Jamaa ako wapi? Where is he?
After all unapata
Where are you right now, sir?
I'm at
Naivasha.
Naivasha. And which hospital are you talking about?
Yeah, I'm working at the beach. I'm a bike rider.
It's okay. Yeah. Which hospital did you try to access?
Like, even I don't think that district hospital.
Okay. Maternity.
Which hospital?
Can you tell us which hospital you went to, you with your wife? Which hospital? Sorry?
Naivasha Hospital.
Naivasha
Sub-County Hospital.
Yeah.
Okay.
Naivasha Sub-County Hospital.
Yes.
What is the gentleman's name?
So, what is your name, sir?
Okay, then the problem is that...
no,
bro,
what is your name?
Is your name?
My name?
Yes.
My name is John Mwangi.
John Mwangi.
John Mwangi.
So let's get this clear, John.
Yes,
that
please.
you went to Naivasha Sub-County Hospital. Your wife was supposed to deliver.
Yeah.
Did you go with your SHA, your shift card? Did you have a card or did you present your ID?
My wife has a card.
Your wife has it. Yes.
Yeah.
Did you present it?
He presented it.
Uh-huh. Walimtibu. Aliza.
Well, aliambiwa service iko available, so I had to go to a private facility where I can get.
Mwezi gani? Siku gani?
Siku gani?
It was last year, December.
December last year.
Yeah.
Okay.
So aliambiwa nini? Sababu gani?
Na just that, nimekuwa bado nikisikia tu kwa hivyo simply because mimi naendesha pikipiki, I'm a bike rider.
We understand. What we are trying to do here for you, John, is that Waziri is here. We are handling these issues one by one. If your wife went to hospital in December, alikuwa ameenda kujifungua, si ndio?
Akaambiwa nini?
Akaambiwa services haziko available na alikuwa ameshalipa, si ndio?
Ndio.
Right? So walisema hakuna services, so alienda private. Ilikuwa mwezi December. Aliambiwa services haziko available lakini alikuwa ameshalipa.
Alikuwa shalipa kwa sasa. Machine ilikuwa na shida, so ilibidi tu niende kwa private
machine
system.
Okay.
So unapata tunatembea unaambiwa mara ngoja na bibi hizo napitia uchungu sana. Kwa hiyo mimi ile singejana nilipitia nikaona sikuona ni mtoto wangu wa kwanza na ni mtoto wa pili.
Okay. Okay.
But nikiangalia another way around, wakati wa uhuru mimi ni mtoto wangu nilipata ngabure, sikupitia shida yoyote. Linda mama ni guard everything. But nikiangalia sasa hivi mtu mwenye anaishi kwa ground, mwananchi wa chini sasa hivi anapitia shida kubwa sana. Pia nini? Lazima hata kilipa. Kabla pale ndio apate usaidizi, anazungushwa.
Okay. Sawa. John, tumesikia. Sasa waziri atadeal na hiyo issue saa hizi. Sawa?
Yeah.
Okay. Asante sana. You can keep listening and just listen to the response that we'll get from Waziri as we take a couple more questions from folks this morning. Sawa?
Yeah. but at least kinawambia at least go try to listen wananchi wa kawaida. Then mimi najua wanakuwa na insurance covered yao, but sisi watu wa chini, watu wanakufa kwa hospitali juu hiyo. Hata nikwambie, mimi napitia, naona watu wakipitia. Unapata mtu amefanya accident akifika hospitali, ana
Sawa. Thank you so much, John. Let's hear from other people this morning. Hello, good morning. Can you tell us your name and where you're calling from?
Hello, I'm Maisori Chacha from Kuria.
Yes.
Ya kutuna swali kwa Miwa Moses Kuria. Tunashindanga na hii SHA. Sasa ni kutesa wanakutesa ama namna gani?
Hello, go ahead, sir.
Sababu hapa Kuria tuko na level 5 hospital. Ukienda huko unapata kunibana dosiko na maybe painkillers, hakuna kitu chochote na SHA ifanyi kazi. Tunashinda tuko dunia gani? Na hata sasa ukienda kama mama wanajifungua, hakuna anything naambia dawa hakuna, na at least kama kijifungua naambia bado lazima ulipe pesa ndio atoke. Tunashinda sasa. Tunaishi Kenya gani ama tuamue Tanzania?
Hospitali gani?
Which hospital?
Hii ni Kuria, ni Kuria level 5 hospital.
Kuria level 5.
Yeah.
Okay.
Anasema what is the problem in Kuria level 5?
He says everything.
Nothing is working.
Nothing is working. Underground vitu ni mbaya sana. Ni venye hata sasa tuna uwezo wa kusema, lakini sasa inabidi tu tunavumilia tu kama Wakenya tu.
Iko town ya Mabera ama iko wapi?
What town? What town specifically? Mabera?
No, Kehancha. Yeah.
Okay. Sawa.
Yeah.
All right. Let's take another call as we're waiting for the response on that. Thank you so much. Hello, good morning. Tell us where you're calling in from and your name.
Hello, this is Kasim.
Yes, Kasim.
I'm calling from Bugoma.
Hello, good morning.
I just want to... Good morning.
If you can just
want to share my experience with SHA.
Don't mind.
Just a minute. Let's take this.
Yeah. Just
hold on 1 minute.
I have a governor of governor habari yako.
Salama ndugu, habari ya wewe?
Mzuri sana. Huyu ni governor wa Migori, Mheshimiwa Ochilo yako. Niko na kwa studio. Na niko na malalamishi kutoka kwa Kuria level 5 hospital.
Yes.
Anasema huko hakuna dawa, hakuna kitu inafanya kazi huko. Sijui, I don't know if you are aware of this problem, Bwana Governor.
Ni malalamishi kutoka kwa a member of the public.
Yeah, member of the public. Yeah, we are on studio and we are taking calls live on Spice FM.
On Spice FM.
Yeah, so this call that has come from this guy in Kehancha in Kuria level 5 hospital.
While we are there,
yes,
let me try and connect to my, while we are there, my chief officer, the one responsible for medical supplies.
Yes.
No, medical services. You can just on them so that they get you the correct information.
Yes, at the same time, Governor would want to know whether the county has any arrangement to, let us say, have a support center for the public so that people don't have to call the media, so that they can be able to call somewhere there in Migori within the Department of Health.
We have, you know, the media does a wonderful thing. The media communicates to the public.
Yes.
Migori County, we have numbers at the CS's office where things can be called. But even this member of the public can actually go to the hostel and talk to the person in charge who will relay that information as members of the public don't have to go through the regular media stations.
Yes.
In order to be attended.
And Governor, within Kuria level 5 hospital, is there a particular desk for where this gentleman could have gone to complain, knowing this is a complaint desk? And I believe we have got a SHA office there. So it is likely that the people of Migori County are not aware that we have set up centers in every hospital where they can be able to complain.
I guess the one question is, Governor, is that this isn't from Situation Room. The question is, where can folks go? If we have one person who is complaining from Kuria, we have a number of people then who would be, and who do we go to ask questions?
questions can, you know, the counties, Migori included, are able to process direct questions from residents of the county who can go there. I wish this person, if this is a resident of Kuria West or Kuria East, and they are in that neighborhood, they could take this number and call, not mine, but the number of the chief officer responsible for medical services. The number is 0721 158 112. If you bear with me for about 1 minute, I can get him, I can have a conference call where he's on board. Then from that number, he should be able to advise more.
I think it is important, Governor, because not just for this gentleman, but
quite a number of
this is an issue that has been mentioned in Naivasha. So I think we have an issue as a government, as leaders, to ensure that people are not orphans. Mwananchi is not an orphan. So I think we are doing wonderful things, but when people get problems, they don't know where to complain, like this particular gentleman. So I think it's better you look for that officer.
Maybe as Waziri, as governor is trying to make that connection, I think it's important for us to, at the very least, be sensitive to the nature of some of these issues. John Mwangi in Naivasha, for example, who had to go through a harrowing experience, watching his wife, in the throes of labor and had to move her. So, I mean, we have to say we're very sorry that John Mwangi had, for John, I mean, you're still listening, that you had to go through that, and hope that nobody else has to go through such an experience.
Yes, Chief Atula, I am on this line with Moses Kuria. You know Moses Kuria used to be a great friend of mine, and he's live on Spice FM. Somebody in Kuria is asking whether our level 5 in Kuria, it's level 5, isn't it? Level 4. It's level 4.
Level 4.
Yeah,
in Kehanja.
In Kehanja. That is Kuria.
Kuria East. That's Kuria East.
Do we have issues with medical supplies there? And two, when there is a complaint about services, or when there is a concern or inquiries, is there a number or a desk that deals with that? We are live on Spice FM. Okay. Well, with respect to the commodities, we had the challenges over the festive period in terms of delivery of those commodities, but we have sorted it out. Right now, we have essential commodities in the facility, Kehanja. With respect to number 2, if there is any concern from the community on how they can address those concerns, we have the MOH, the officer in charge of medical health within the sub-county, who provides contact through the CHPs where they can be able to send those concerns and we address them as they come in.
Sorry, sir, I just have to be very clear, because these are people with real life situations, in some cases emergencies, that try to get on a platform for in some cases where they cannot. So we need to be very clear with them about who they can go to, what number they can call, which person with a name, an actual human breathing that they can speak to. So who is this person? We can say CHPs, we can say MOH, but who is that? Who are these people?
Okay. If it's general concerns, it's the CHPs to the MOH. And if it's an emergency situation, we just have an emergency referral system, whereby at the sub-county level, there's a number which I can get immediately after this. I don't have it. The MOH? Who is the MOH?
Who is this person at the MOH?
Okay, the MOH for Ansha is called, for Kuria West, is called Justice Arodi.
So our caller who just called and had this particular issue can call a gentleman or ask to see a gentleman called Justice Arodi.
You have Justice Arodi's number, or is it just called Justice? Justice Arodi. I have the number 07 00
00
55 55
35
72.
But I think, Governor, not every time I'll be in Spice FM. So we need to have a mechanism for a normal border guy there in Mabera
to know who to call,
and that needs to be.
Actually, there is.
Yeah, so no, we need to have a campaign there within the county, for people to be sensitized in barazas and everything. That
I think it's availability of information, but there is. What normally obtains in counties, we have CHPs who are volunteers, and they are available all day. They know the villages and all the community. They have them. Even whoever is in any village there, one can reach there. That is ordinarily. But at those facilities like Kihancha, like the others, there is an MOH, and that MOH and the numbers are known. And in event of an emergency, they can actually call specifically there.
Okay.
But we are happy that the public can call the media and bring the attention of the media and also of us and yourselves about the presence of an emergency or the need to sort out something.
Another major issue, Governor, as you know, that once we roll out the hospital information management systems in all your hospitals within Migori County, all these claims can be verified on the system. Right now we have no way because doctors are writing on pieces of paper.
Yeah, that's true.
Yeah, so once we roll out the digitize the facilities, same thing we are doing with Governor Abusab and Sharif Nasir in Mombasa, that once every facility is digitized, from the minute the patient walks in to the minute they go away, even if a patient is turned away, the doctor will be obligated to write on the system why they have sent him away so that you can be able to, to audit it. And we hope that we can be able to complete this in Migori County soon, so that it's not our word against their word. It is something that is verifiable and scientific.
Governor Yako, I want to thank you for that. Just want to reiterate that I think it's extremely important that even though we say that information is known to people, that it must be in a public arena. People's numbers, if they need to be pasted on a bulletin board somewhere in each facility, I think it's necessary to have, rather than for us wait for a situation like this where somebody's looking for a number and we have to, make this connection. I think that information must be public, Governor.
I want to absolutely tell you that the people who are on the ground and use these facilities know how to get there. But I'm not saying that that is 100% the situation. But majority of the people, if you know where Kihancha level 4 is, if you know the facilities feeding into Kihancha, you are likely to know what to do. Okay. It's just unfortunate that perhaps an individual or a few individuals may not have been adequately aware of what is supposed to be done. But by and large, it's available. Those who use other facilities, Beidei, Nawendo, Isuna West, Nyatike, Kuria East, Kuria West, by and large are able to access them. And just like the CS, Kuria has said, it is work in progress. We are improving, we are digitizing, we are going on.
All right.
Thank you very much.
No funding.
Asante,
and we went to school together, so you cannot let me down.
And there'll also be an opportunity for us maybe to invite your CEC to the studio, Governor.
Around, I believe in devolution, and you know it will get done. What we really want as counties is more resources devolved, more support from the national government. I'm not saying that we are not receiving it, but we need more.
Asante Sana.
Thank you.
All right. We'll take a few more calls from you as we get into that. And I know a lot of people have been holding for a while. And let's take some of that call from Saina in Narok. Good morning. What's your question? Hello, Saina. Good morning.
Hello, this is Saina Welenkako Narok.
Yes. What's your question?
My concern is where to make an appeal in case kutosheka na vile wanavyo kulipisha. My example is as follows. While I was niliretire, nilikuwa nalipa 500 kwa NHIS. Sasa nilipoenda kusajiliwa ninaambiwa 1,330, more than double what I was paying. Sasa hii inaniput off. Sasa nashindwa kwani wanatumia vigezo gani? Vigezo wanazozitumia wanasema do you have a ready? Every home have a radio. A TV. Unapika na nini? Hata kama ni meko. Unakaa nyumba gani? Some of these things has sina mimi, I'm a very old man. Kama ni shamba already naulizwa niko na shamba kiasi gani? Shamba nimepea watoto wote. Mimi have no shamba. Mimi just house. Haya, kama hata ndio gari ninatumia nikununulia na watoto they are taking care of me. So kwa life total continue with the 500 or at least to 300. Sasa nasia I'm paying double. Hapo inanishinda. Sasa where does the person take the complaint aende ajiseme jeni vile ilivyo kuliko hiyo machine, kama maana nikusajili pale hana shida, ni machine imekuweka.
Okay. Thanks, Aina. We'll address that. Thank you very much for calling. Just keep listening as we do that just shortly. Hello, good morning. Tell us your name and where you're calling from this morning.
Hello, good morning. Tell us your name and where you're calling from.
If you could turn down the volume on your radio, that would be fantastic, or your TV.
If you could turn down the volume on your radio, that would be fantastic.
Hello.
Hello, good morning.
Good morning. My name is Joseph.
Yes, Joseph.
I'm from Mombasa.
Yes, Mom. Yes.
Swali langu ni kwa waziri. He's saying that Mombasa is doing well. Last week I was in the hospital, Coast General, and I'm registered with SHA because I'm working. I was told that SHA haifanyi kazi kwa mtu ambaye anaenda kuona daktari, labda awe amelazwa. So I had to pay 400 shillings to see the doctor. When I went to the doctor told me that I was to do a scan. The scan was, he told me that it's 8,000 Kenya shillings. And he directed me to someone called Dr. Oyuasi. He told me that I have to pay that guy the money, not to pay in the system, just to pay that guy 8,000 shillings to do the scanning. So I went back and then I thought about it. So I went to another clinic which uses SHA. So the clinic told me kama sijawahi enda pale nikiwa natumia NHIF,
Dr. Wanjiru, how are you?
Fine, thank you. How about you?
Okay.
Good, you are live on air. I have a patient who is also live on air.
Joseph, you can speak directly. Just hold on a minute.
This is Dr. Wanjiru Kuria, the Deputy CEO of Coast General Hospital. Sasa huu mgonjwa nataka aelezee tena ndio usikie shida yake. So tena sema tena Bwana Joseph, ulienda Coast General ukafanyiwa nini?
Nikaambiwa siwezi tibiwa, hawachukui
outpatient. Hello?
Hello?
Anasema aliambiwa hawezi kutibiwa outpatient at Coast General.
Yeah, as level 5.
At level 5 because alipaswa kwenda kwa ile ingine inachukua level outpatient.
Yeah, as a referral, yes.
As a referral. Ndio tusipate msongamano katika level 5 zetu. So niambie huyu Joseph sasa sababu alikuwa hapo. Yes. Si ageenda level 4. Ini level 4 gani iko karibu na hapo ama level 3? Chuda ageenda Chuda. Iko Chuda iko walking distance ndio.
Okay. Daktari, because Joseph has dropped off the line, this is just important for him and for anybody else. At the point whereby instead of being told that he cannot be treated, would the secondary information have been given that since you are here at Coast General and we can't attend, that there is another hospital that can attend? Tuda, for example. This information is coming after the fact. This is the question after the fact. This is new from Spice.
Sasa vile tunamwambia sasa, what we are telling this patient on live radio, was that information also relayed at your facility, so that we know that we are told, excuse me, because now we have a new policy whereby to allow people who need superior services as Coast General, for services like outpatient, please go to Chuda. Was this relayed to are you relaying this to the patients?
Yes, they're even told if they need to go to a health center, there's one at Makadara called Kadaboy. They're given the options that are close to them.
Yes.
Yes.
Okay.
So get the point.
Sadly, we can't confirm this with Joseph because he's dropped off the line. But it would appear as though he was a bit frustrated, and because he had gone for medical assistance, in the next 2 weeks, I would have imagined that he would have gone to the
Digitized Coast General. Even when Joseph is turned away, he could have been entered on the system and told we have been referred backwards to Chuda. You see, you get the point. But right now, it's our word against Joseph because no one was there. And this is the whole essence of digitization. Because digitization will help us to know what happened at Coast General, even when me and you are not there.
Right.
Yeah? Because right now, we don't know what happened. We don't know which doctor. We don't know anything. And that's the whole essence we are doing digitization. Because now, Dr. Wanjiro would have gone to the system, search for this particular patient, see who treated them, and if in any case, even if something wrong was done, Dr. Wanjiro would have been empowered to go and know which doctor did not give the right service. Thank you, Dr. Wanjiro, and have a good day.
Thank you very much. All right, continuing this morning, and Senior Advisor in the Economic Council of Advisors, this having a conversation around SHA and many questions coming in from Kenyans in terms of what do we do when stuck. We're taking your questions. Hello, good morning. Tell us your name and where you're calling from.
My name is Joseph Msioki.
Yes, Joseph.
Napiga kutoka Machakos. I want to congratulate the waziri because of what waziri is doing. I think kuna shida ya information because I had a case nilipeleka my friend to Machakos level 5. Then we were told angefaa kuanzia level 4. So I wish to request waziri kama hawa wahudumu wa afya wanaweza kuwa na meeting hata kama ni barazas. Then they sensitize they tell the information to the common mwananchi because mtu anatoka akiwa na mgonjwa wake anaenda to level 5 because anaamini hapo ndiye atapata usaidizi, then akifika pale anarudishwa huku chini. So Wakenya wakaelezewa vizuri, wakajua tunafaa kutoka hapa chini tukipanda juu. I think itakuwa vizuri sana. Again, I want to kupongeza watu wa Spice Media because all the media, zile media zingine, they are not bringing the positive things zile zinafanywa na SHA.
Niko kwa studio live studio, uko kwa live studio.
Sorry, if we can just
na kuna Joseph kutoka kwa kaunti yako.
Ndio.
Ya Machakos.
Ndio.
Anasema watu wanatoka kwa level 4 wanaenda kwa level 5. Akifika level 5 ndio anaambiwa hapa ulikuwa urudi kwa level 4. Na ashatoa mgonjwa nyumbani. Sasa ningetaka kuomba tufanye mpango. Tukuwe na baraza ya kuhamasisha wananchi wajue ni lini unapaswa kwenda kwa level 1, level 2, level 3, level 4, kwa sababu sio makosa yao kwamba washafika kwa pale Machakos level 5 na washatumia mpaka nauli yao.
Yeah, because but if the patient is very sick,
yes,
you'll be able to take them.
Yes.
But a patient is normally has to go to level 4.
Yes.
Then level 4 now refers them to level 5.
Yeah, but also we need to fast track the digitization of the hospitals.
No, actually I already digitized.
So that now the referral from level 4 to level 5.
Yeah.
Level 5 can be waiting for that person even before they come.
Yeah.
But the system is not even the issue. The issue is this innocent person from Masi.
Na kwa hata Masi kuna level 4.
Exactly. Sasa lakini sasa
the number of the person.
We will send you, but the whole point, Governor, let us do a campaign for the public ndio watu wajue, watu haribu muda na pesa.
Sawa, nimekuelewa lakini nipatie. But they know we normally it's okay, we will do it.
Yes.
But our process is that when you go to level 3 you're not okay.
Yes.
You're referred to level 4.
Yes.
From level 4 you're referred now to level 5.
Absolutely.
Because level 5 is just we only take referrals.
Yes. So we are doing the right thing, but hapo communication tuko na shida kidogo.
We're opening a level 3.
Yes.
Opposite to the level 5.
Yes.
Because people have been coming with issues of level 3.
Absolutely.
Level 5.
Absolutely.
And level 5, we should be dealing with a very serious cases.
Okay.
Okay. And you know, it is a question of time because once you communicate to them and you recruit them, you don't even need to open because people will know where to go.
No, but we are opening because because of the Machakos Central Apple.
Yes.
Yeah.
Asante.
Thank you, Governor.
Yeah, can I have the number so that we can try and help them?
Yeah, well, let us
we will take the number. So what we can do, sorry, if we can take the number and Mr. Kuria will send it to you, Governor Ndeti.
Okay,
but also, Joseph, I think you did have something that you needed to clarify on.
Yes, Waziri. I think before I have heard what the governor said, but before they open that level 3, the problem is not the system. The problem is communication.
Yes.
Yes, the way we do public participation in finances, everything, the way we do public participation, kindly let us do public participation in SHA.
Indeed.
Because medicine is everything.
Okay. Joseph, thank you. Definitely heard. Thank you very much for your comments. Let's take some other calls this morning. Hello, good morning. What's your name and tell us where you're calling from?
I'm calling from Bungoma.
Yes.
My name is Kasim. I think whatever I wanted to say is just to insist on what Joseph was saying from Machakos. I think sensitization is the most critical thing here. I've visited a level 4 hospital back then, and on December my wife delivered, and I got an excellent service from one of the hospitals here in Bungoma, Elgin. I hadn't registered. I hadn't added my wife into my SHA, so I got an assistance from one of the attendants, and she told me it was possible. So she assisted me through everything, and she was admitted, and everything was taken care by SHA. Okay. But the only thing that is a challenge to most of the patients is the difference, like what SHA is doing to inpatient, outpatient. You find that somebody goes to a hospital, is told that SHA is not working on outpatient. It only works on outpatient. And I refer to the guy in Mombasa who also highlighted the same issue. Okay. So my question to Waziri, to be on point, as much as SHA is doing exemplary good job to Mwananchi, what is the difference in serving both inpatient and outpatient, and what is going on between the two? And
all right, Kasim, we'll take that question as we take a couple of others, and Waziri we'll get to that. Is that okay? Yes, sure. I want to take a couple more, and then we can do that all together. Is that all right? Eunice, you've been holding for a while. Good morning. Hello?
Hi, my name is Eunice.
Hi, Eunice. How are you? Good morning.
Morning. I'm a sickle cell patient, sickle cell advocate, and I'll not lie to you. Sickle cell does not get what it needs to be done in this country. Because number one, we are children who are born with the disease. We inherit the disease from our parents. So number one, from screening, we need the government to take initiative to make sure that we get screening for free. Number two, we need our medication to be free because we take medication every single day. With NHIS, depending with the facility you will go to, we had already negotiated as the Federation of Kenya for Sickle Cell to get 300 and you'll get sorted. But right now with SHA, every single person has to go off pocket. And don't forget, sickle cell is a very expensive disease. So, and it happens that in a family you'll end up being free of 4 children who have the disease. I know when the SHA was being launched, we were told sickle cell will get the package of 6,800. That is less than one admission I will get as a patient. When it comes to screening, right now they say they'll do free newborn screening. We have never had anybody being screened for free. We keep on losing patients every single day because of mismanagement, misdiagnosis, and because sickle cell presents itself like malaria. We don't have malaria. It's a sickle cell disease. It's something you inherit. So all we are requesting for, can SHA just take care of us the way other people do? Because when you come to private insurance, already we have clustered that, like, this is a chronic disease.
Yeah.
So I'll not get my medical cover. I have to wait for 2 years to be covered. And that's why we are fighting for the national insurance to cover for us everything, like other countries. Because in Kenya, we don't even have a registry of how many people are born with sickle cell and how many die every day. We don't have that. And if they can include this in terms of when they're doing the population census, it will really help us to get the registry going.
All right, Eunice, let's allow Waziri to talk about that, because there is space, for what we've been told, within the authority and within the fund for
but I hope that
some
Eunice
conditions.
will give you her number.
We'll have,
because it sounds like they have got an organized way for as a federation or something, so that I can be able to pass that number to Dr. Patrick Amol, our Director General for Health, who is leading the effort of reviewing the tariffs, because these are the kind of things that we now need to factor in the second wave of the review. That is the first point. So it is going to be a very public process. It's not going to be something done in darkness. So people like Eunice and who represent special interests like sickle cells are going to be whatever. So if Eunice if someone can get Eunice's number, that
Lydiah will get Eunice's number, and then that we can be able to share.
But the second point coming from Eunice, presentation is the whole thing that I'm saying about ECCF, the emergency and critical care, and also the chronic illness fund, because, the way we designed this system, everybody was mapped. People of the ICU and HDU, they were mapped. People of sickle cell and other chronic diseases, they were mapped. So the whole design is there. Of course, sorry for saying this again and again, once the liquidity comes into the system, all these funds will be able to be capitalized so that we can be able to look at people with chronic illnesses like sickle cells. So, one, let us pay so that we get more money. Two, let us capitalize all this chronic fund. Three, because we are reviewing the benefits, we are not going to do it like we know it all. We are going to, work with people like Eunice to be able to give us, knowledge which come for free for us in terms of as we shape the benefit structure going forward. But then going back again to the issue of Joseph, I want to promise Joseph and Kasim and those people, that issue of communication, that issue of customer service for SHA, I will fix it.
Okay.
And the government will fix it.
A couple more questions. Let's take them this morning. Hello, tell us where you're calling from. Good morning.
Hello, tell us where you're calling from. Good morning.
Hello.
Hello, tell us your name and where you're calling from this morning.
I'm Joseph. I'm back again.
Oh, yes, Joseph.
Yes, I was... I just my credit was low, so I just wanted to clarify something with Waziri.
Okay, real quick.
Okay, so when I went back to the hospital, I told you that the Coast General.
Coast
General.
Yes,
I'm from Mombasa.
Yes.
I'm from Mombasa.
Yes.
The doctor, because mine is I have a problem with my head, the veins. So the doctor told me that I have to pay 8,000 to do a scanning.
Doctor who?
I don't know Doctor who, but I remember it was on last week, but one, and he gave me a number of the guy who was doing the scanning, and the guy told me that I have to pay him 8,000 Kenya shillings.
Joseph, this is very serious. I want you to give your number.
Yes,
I'm going to get your number, and I will personally call you because I want to know what exactly happened. As you know, I'm trying to set up Mombasa as a best practice, so I would want to know, and I want to tell you that even on New Year, when people are celebrating New Year, I celebrated New Year in Coast General, solving problems like this, and I know some few things are happening there which needs attention. So I will be calling you. Nitakupigia simu.
Because even mimi nilifanya kutafuta usaidizi kwa Chinese hospital.
Okay.
Which is based on Tuesday. Because my problem was critical.
Okay. So what we'll do in this case, Kuria will have your number. We will share that with him, and then this will be able to be, it should be addressed. Because what you didn't know is that when you were off the line, I don't know if you were listening, is that we did have the deputy from Coast General, and she said that you should have actually, yes, Dr. Wairimu, you should have actually, you should have actually been referred to TUDA, which is not far from CGH, but that did not happen for some reason. So it would be nice to get some clarity on this. So Waziri will call you, and I know he will when he says he will, and so we'll share your number with him. Is that all right?
Okay, so if someone maybe is have to take to go to medical attention, so I have to start from level 3 or level 4.
Yes,
so,
correct.
Yes.
I have to start from level 3.
Yes.
And then I'll refer to level 4 all the way going forward.
They will
Even
tell
if they
you.
cannot help you,
They will tell you.
Okay.
All right.
Sasa shida ni kwamba haukujua hivyo bwana Joseph.
Sikujua kwa sababu and the lady alikuwa kwa counter. Hakuniambia tu kwamba nataka niende level 4.
Okay.
Yeye aliniambia hatuchukui watu ambao ni inpatient outpatient, na
hakukuambia uende TUDA. Hakukuambia uende TUDA.
Hakuniambia kabisa. Hakuniambia.
Hapa kuna mashtaka ya kujibu kwangu.
After hapo nikaenda Kisimani health wakaniambia hawachukui watu ambao walikuwa wanahudumiwa kwa SHA kwa sasa. Wanatumia tu wale watu walikuwa wanatumia NHIF zamani.
Okay.
Na mimi nikamwambia hadi NHIF, lakini sijawahi kuwa mgonjwa, nimekuwa mgonjwa sasa nikiwa niko kwenye SHA. Unaona?
Okay. Nikuuliza Joseph, wewe umefanya means testing, unalipa?
Mimi nalipiwa na kampuni.
Unalipa na kampuni, sawa. Bahati.
Nalipiwa na kampuni.
All right, thanks for that, Joseph. Let's take a couple more calls. Hello, good morning. Tell us where you're calling from and your name.
Good morning.
Yes.
My name is Wilson. Thank you for picking my call.
Thank you for holding.
First of all, I want to... Okay, thank you. I want to commend Sparks FM because the issue you're bringing directly contacts the public, especially it's a concern to us. And also for Waziri to be present today to bring some light in terms of SHA and everything, we appreciate that. However, I have some few points to put across, especially I live in Nairobi, and as you know, within the estate, especially within Embakasi, specifically pipeline, we don't have public facilities, majority of them. Especially pipeline, we don't even have a public hospital. I had some issue, a chronic issue in this case. I visited Mama Lucy. Yes, it was crowded, but then I was able to see a doctor at long last. But then in terms of medication, I was told to buy medicine from outside. Remember, I work with a company that pays for my SHA. Of course, I had to because I was sick by then. Also, the same pipeline where I stay, back then I used to go, when I had NHIF, I used to go to Bliss Hospital. I could get medication and everything. However, just last week I visited. I rarely get sick, but then last week I visited. They were frank enough to tell me SHA only provide maybe around 900 or less for my medication. So I was able to see a doctor, but in terms of medication, they just had to write, and I had to chip in.
And so you had to, leave the hospital to go and buy from an external facility, or you had to buy in the hospital?
I bought in the hospital.
Okay.
They told me right there, believe it's just within pipeline stage, next to Bata.
Okay.
You can confirm that.
All right.
So that hospital that you, the place you are sent to buy is not inside Mama Lucy, but outside. But next to
the Mama Lucy issue. I got treatment, but then they were out of medicine. I could understand that. I had to buy. But then the Bliss, they told me the kind of cover I have, that is SHA, they were only able to provide less than 900 shillings. That was
for medication.
To enable me to see a doctor, not medication, to see a doctor. So in terms of prescription, I could not get medicine unless I chip in my own cash.
All right.
So I had to pay 2,500 just because the 900 shillings they were talking about could not even enable me to do a test, a simple blood test to see exactly what I was going through.
Okay.
My friend, what's his name
Doctor
again?
Consultation.
This is a very important case.
My name is Wilson.
Wilson, yeah.
Wilson, nataka nitachukua namba yako because I want you to send me the receipt of the money you paid.
Okay.
And I will follow up this with Governor Sakaja. Because I don't believe.
However, I can't. Yes.
Because I can't tell from here because from you are just an outpatient, someone going to seek service. Apo Mama Lucy. You are not admitted or anything. You are just want to see a doctor and you are told to pay.
Actually, what I was suffering from, to be specific.
Okay, so let's get this clear, Wilson.
Yes, please.
You went to hospital. You saw a doctor. You were supposed to buy some medicine because they said what you had left on SHA was not adequate for the medicine you needed, right? And you had to pay to the amount. So you had to pay to the amount of 2,500 shillings, for which you thought your SHA card should have actually covered. Am I right?
Exactly.
All right.
Exactly.
So that's where we are. And Moses Kuria is saying that you should not have paid that money if you're paid up for SHA. So what we are going to do is share your number with him, and he's going to get in touch with them. For if you have the receipt and all of this, you need to have that ready. So when they have the conversation with you, because it's clear from where we are that you should not have paid that money, right?
It's okay.
All right. So let's do that. There are so many calls. There's so many people who have questions. But our time is wrapping up. But I would like to give you a minute and a half, rather actually a minute, to wrap this up and give us one of the big ticket issues that we are seeing here is communication of where people should go, what they should do, who they should speak to.
I want to come back here again within maybe the next few weeks or so. Once I re-engineer the whole architecture of communication from governors, and I'm going to be meeting the CECs for health. Today I have a meeting with the CEO of the Council of Governors so that we can organize a meeting with CECs for health, and ultimately I'll be able to call a meeting of the governors so we agree on who communicates what and who supports what. As you can see clearly, doing the gentleman here, is that the whole thing boils down to communication, awareness, and everything. That's number one. The other thing that it's boiling down to is non-compliance by facilities. And these are human beings. Part of it, once we digitize all the facilities, and that's why I'm on overdrive of digitizing all facilities, so that all these claims can be verified on the system. Like this gentleman who was told pay, blah, blah, blah. If that facility is digitized and it is not digitized, we could be able to see. So we have a problem of compliance by the facilities, but that would be resolved once we digitize. So I think I pick up three things. One is communication. The second thing is compliance by facilities. The other thing is about digitization. And most important thing is all of us to agree to pay. All of us. So that this system can be well oiled. It's a harambe. You can't have few people in this harambe contributing. Let's all of us contributing this harambe.
Moses Kuria, Senior Advisor at the Economic Council of Advisor, thank you so much for being here this morning. We invited you for breakfast, you've stayed for lunch and dinner, and at least been gracious enough to answer questions and at least colour them with quite some honesty. Thank you so much, and we look forward to the next time where we can streamline a lot of these issues.
Thank you very much.
Thank you all of you who participated this morning and also bringing your issues to the fore. It's what we do on Kenya's Biggest Conversation. We'll continue again tomorrow.
This is the Situation Room, the only way to start your day.